All right, let's go ahead and get started. Welcome to today's webinar. Today's webinar is on CMT, and we're so grateful to have our speakers here today to share more information on CMT. As many of you know, we just held a very successful walk for CMT this past weekend, and we really thank you all for your support. It's an exciting webinar today as we have Dr. Gerald Pfeffer, clinician researcher in genetic neurological disorders. Dr. Pfeffer is an MSAC member and is really a great supporter of MDC. He has completed his medical school training at McGill University, his neurology residency at University of British Columbia, and a PhD in genetics at Newcastle University in the United Kingdom. He is currently an assistant professor at University of Calgary, and his clinical and research work focuses on adult-onset neurogenetic conditions. I should mention before I continue that today's webinar is simultaneously interpreted in French, and so you will be able to access the webinar in English or French, the language of your choice. On your screen, you'll see an interpretation icon. You can select the English channel or the French channel. I'm going to go ahead and pause and pass it over to Marie-Hélène to explain these instructions, and then I'll introduce our other speaker as well. Marie?
Oui, bonjour tout le monde. Alors, bienvenue à ce webinaire sur la CMT. Il y a eu la fin de semaine dernière une marche sur la CMT. Nous vous remercions tous d'avoir participé à cette marche. Je voulais vous expliquer que la présentation est disponible en français aussi. Alors, vous pouvez sélectionner le français dans le bas de votre écran. Il y a une icône interprétation en forme de globe terrestre. Vous avez qu'à cliquer dessus et sélectionner French et vous allez entendre la présentation en français. Alors, merci. Bonne présentation.
Thank you very much, Marie. Thank you. So I'd also like to welcome Dr. Stephanie Plamondon. She is a clinical associate professor for the Department of Clinical Neurosciences at the University of Calgary. She trained in human kinetics from the University of Windsor and then moved on to complete her medical degree and training from McMaster University. She's also completed her physical medicine and rehabilitation residency. In her clinical practice, she focuses on neuromuscular rehab and medical education. Similar to Dr. Pfeffer, we really appreciate that Dr. Plamondon has been a great supporter of MDC and that has always really offered supports to our CMT clients and also other clients affected by neuromuscular disorders. So thank you both for agreeing to speak at today's webinar, and I'll pass it over to you.
All right, good afternoon, everyone. Nice to be getting together virtually yet again. I hope my screen is showing. Hopefully, people will send tomato emojis to me if my screen is not showing. So we'll be presenting about CMT 101. Dr. Plamondon and I will tag team this lecture, and I will talk more about some backgrounds and diagnosis of CMT, and my colleague will be talking more about the management and the experience of living with CMT. First, some disclosures. I do not have any competing interests relevant to this presentation. I do volunteer on advisory boards, including for Muscular Dystrophy Canada. And I wanted to take a moment to do a territorial. I'm presenting from the city of Calgary, which is on the traditional territories of the people of the Treaty 7 region in southern Alberta. And the city of Calgary is also home to the Métis Nation of Alberta in Region 3. So we'll give a little overview of this presentation, which is really meant to have a little bit of something for everyone. It's meant to provide a little bit of basic background for people who might be newer to learning about CMT or who do not know as much, but also to have little tidbits that may also be of interest for any healthcare workers who may be attending today and people with more specialized expertise. I'll talk a little bit about what is neuropathy, when is neuropathy genetic, and an overview of CMT and the genetic neuropathies. So what is neuropathy? This is a disease in axons in the peripheral nervous system. This can disrupt our sensory function, or our ability to sense things, our motor function, the ability to move, and our autonomic functions. So these are automatic functions controlled by the nervous system, such as sweating and blood pressure control. This is a little cartoon showing us approximately what a neuron looks like. You have the cell body over here, where a lot of the action and activity occurs to keep the cell alive. The axon is this outgrowth coming out of the neuron through which signals are sent. There's this little material called myelin, which insulates the axons to make sure that electrical signals do not degrade as they are in transit through the axon. And finally, there's the axon terminus, or synapse, where you can transfer information from one neuron to another. So generally, the problem in neuropathies is affecting the axon, either this conduit itself or the insulation surrounding that conduit, which results in altered transmission. So this is a little cartoon that kind of summarizes what that looks like. You have processing in the cell body, and the message goes through this axon here. You should be aware about the central and the peripheral nervous system. CMT and neuropathies are peripheral nervous system disorders. The brain and spinal cord make up the central nervous system, and signals that come in and out of the brain and spinal cord are carried through the peripheral nervous system, which are all these nerves that go throughout your body. The muscles, by the way, are also part of the peripheral nervous system, and it's a bit of a misnomer. You know, people like me who work with the peripheral nervous system always get a little bit offended when people show just a picture of the brain and they say, here, the nervous system. But really, the nervous system is anywhere. You go anywhere in the body, you've got a part of the peripheral nervous system doing very important functions. Interesting facts about the peripheral nervous system is that part of the autonomic nervous system is performing automatic functions throughout your body, particularly in the gastrointestinal system. There are studies that suggest there is more information going from the gastrointestinal system to the brain then there are signals going from the brain to the gastrointestinal system. You can make of that what you will. It might be why we're always hungry and so motivated by food. But it also, lends itself to other important areas of research, such as the microbiome or the bacterial composition inside of our organs, which actually can have an important impact on many different neurological diseases. Another interesting fact that I always like to mention is this peculiarity about the sciatic nerve and filet mignon. So in the Old Testament, Jacob has a fight with this angel, and he actually gets sciatica and injures his sciatic nerve. And so as punishment to the children of Israel, they are told they can never eat filet mignon again because that's basically the psoas muscle where the sciatic nerve is passing. So it's just another peripheral nervous system fact that you can think about next time you're having a good steak. So what is neuropathy? Neuropathy can be focal or diffuse. It is any time you have injury or damage to a nervous structure. A focal neuropathy is when you have damage to a nerve due to vulnerabilities such as at compression sites like the sciatic nerve that we just mentioned from the biblical example, trauma or injury, but less commonly and of interest to this group, it can occur as a diffuse process, meaning affecting nerves all over the body at the same time. And we always look for endocrine or hormonal reasons or inflammatory reasons, but when we don't find those, we start to look for genetic causes. These are common focal neuropathies, which are very, very common if you have compression at the median nerve, for example, or the radial nerve. These are some of the damage patterns that we look for as neurologists when we're trying to diagnose these. A diffuse neuropathy, where nerves all over the body are being affected simultaneously. We often use the term polyneuropathy for this. And the longer nerves are generally more vulnerable. And this makes sense because the axon is considered that sensitive structure that gets affected in disorders like CMT. If your cell has a larger axon, there's more vulnerability for damage to occur. So generally in these diffuse neuropathies, it can have this type of pattern of injury in the red here, where it can have a glove and stocking distribution, where the further regions from the central nervous system are more affected than the closer regions. And as the condition progresses, it tends to migrate upwards to affect shorter nerves. There are a couple of damage patterns that we use as neurologists to describe neuropathy that many of you may be familiar with if you've spoken to your physicians about it in clinic. Generally, we talk about axonal or demyelinating pathology. As I had mentioned before, you have the axon or the conduit itself, or the myelin, which is this sheath that provides insulation for the nerves. And as a general rule, there are differences in the types of symptoms that will occur depending on whether axonal or demyelinating injury is occurring. When is neuropathy genetic? Clinically, we look for evidence of a lifelong condition. And this will be by asking questions about when the symptoms started and when symptoms could have started that may not have been attributed initially to neuropathy. And then we also look for this in our physical examination. So this is an image of the finding that we refer to as pes cavus, this high foot arch, the hammer toes, and the intrinsic foot muscle atrophy. So these are physical findings that tell us, well, this patient who has neuropathy has really had it for a very long time and suggests a genetic disorder. The other time that we may think that we're dealing with a genetic syndrome is a genetic condition is if there is a combination of neuropathy with other features that tend to go together in genetic conditions, such as, for example, hearing loss. And the other fairly obvious reason that we may consider a genetic condition is when there is a family history. Whenever we see that neuropathy is passed down from one generation to the next, as seen in this family tree over here, we tend to think it's more likely to be a genetic condition. And most forms of CMT have what we call dominant inheritance patterns, but there are others that are seen as well. I'll do a quick overview of what the different inheritance patterns are. We have basically, by way of background, we have 23 chromosome pairs. 2 of these are the sex chromosomes, which determine whether we are male or female. And one of each chromosome is inherited from each parent. Women have 2 X chromosomes, men have 1 each of X and Y chromosomes. And we have a separate mitochondrial DNA, which is only inherited from women. This leads to different inheritance patterns depending on where the mutation is causing CMT. The most common one I mentioned is dominant. That's where a single copy of a mutation is sufficient to cause a disease. In a recessive condition, you need mutation in both copies of the gene in order to get disease. X-linked disease typically affects men because men only have 1 X chromosome, women have 2. So usually the second X chromosome can compensate if there's a mutation on one of them. And I have some cartoons that I'll go through quickly, but the dominant one is the one that I want to focus on, because the vast majority of CMT cases do have what we refer to as autosomal dominant inheritance, where you have a single mutation on one copy of the gene that causes the disease, even though there is another healthy copy present. So if the man over here, for example, has CMT, and they have 4 children, it doesn't matter the sex of the children, male, female, not important for dominant inheritance. They have a 50-50 chance of either inheriting the mutation, this copy, or inheriting the healthy copy and becoming affected or unaffected by the disease. The proportions are a little bit different for recessive inheritance, where you need 1 copy from each patient. And basically what you end up with is a 25% chance if both parents are carriers. But of course, this child here, when they grow up, they can only pass on 1 copy of the mutation. So their children will be carriers, but they will not have disease unless their partner is also a carrier. And then I'll go quickly through, I'll kind of skip through these because I want to allow enough time for the other topics here. But you can look up if you're interested. So what is finally CMT? So CMT was a condition originally described by these 3 physicians, Charcot-Marie-Tooth, and comedically has been represented using this picture from the CMT Association. Funny name, serious disease. I apologize that this image does not translate well to French. I guess this would be requin au mari dent. Anyway, but there's a lot of cute little images that you can find of sharks in association with Charcot-Marie-Tooth disease, t-shirts and various other paraphernalia as a result. But it is, of course, a serious disease. And it does consist of a number of different conditions. We are not talking about just one disease when we talk about CMT. We're talking about many different genetic conditions. And if you want me to tell you exactly which genetic conditions fit under this umbrella of CMT, I will not be able to give you a good answer, because it is heavily debated among neurologists which disease categories really qualify as CMT. We do have a number of conditions that were initially defined as CMT by Charcot-Marie-Tooth and various other early neurologists called classic CMT. But there are other conditions that don't have all the features of CMT, but still fit under a general category of hereditary motor and sensory neuropathy. Those probably also get included as CMT. And there's, of course, Dejerine-Sautas syndrome, which is a very severe early onset form of CMT. That probably also gets included as a form of CMT, because in general, the same genetic conditions that cause this syndrome can also cause CMT. Now, the other question is, does hereditary motor neuropathy get included as part of CMT? Most people will say yes. The reason for this being that several of the genetic causes of pure motor neuropathy are also causes of CMT. So for some reason, even with mutations in the same gene, you will get motor and sensory involvements like you see in CMT, or just pure motor involvements. And then it gets progressively grayer in these categories of disease, whether conditions like sensory neuropathy or sensory and autonomic neuropathy should be included under the umbrella of CMT. And most people say they probably should not, because at that point, you're starting to get into very different genetic causes. In terms of how CMT is diagnosed clinically, there are a few things that we are looking for as physicians. The classic features, again, I'd mentioned before the pes cavus and the hammer toes, which occurs because the small muscles inside the foot are weak, and over time it results in a change in the bony structures of the foot. Some of the other changes that we see are, again, a consequence of the longest nerves being affected first, where you have atrophy in the calf muscles and the lower leg muscles, as seen here. And in this picture, you can also see that muscles in the hand have some atrophy to them as well, atrophy or shrinkage. And again, this is a result of longer nerves being affected, and over time, there's a dying back effect. In general, we are looking mostly at motor symptoms and motor signs on examination. And in general, these are features that occur in distal muscles, meaning further from the body's core. But patients with CMT also do develop sensory or autonomic symptoms. Sensory meaning numbness, tingling, and autonomic symptoms, which can include things such as alterations of sweating, blood pressure control, breathing functions, bladder functions. But these symptoms are considerably more difficult for us to characterize, and they can occur in other more common diseases. So generally, we tend to focus on these motor symptoms for that reason. Patients with CMT, depending on the genetic type of CMT that they have, can also have involvement of other systems of the nervous system, which are listed here. And as I mentioned before, family history is really important to us in getting a diagnosis. We'll also often ask about ethnicity because sometimes that has relevance to the genetic cause as well. Here are some of the findings that we'll use as neurologists to help us reach a diagnosis. We'll have a nerve biopsy represented over here, which shows what you see in CMT1A, that is a demyelinating neuropathy. And in dark blue, that's showing us where myelin should be. But you can see that it's markedly reduced in this sample, which is what you would expect if there was some kind of malfunction of the myelin. And then in this panel over here, they're showing us an example of what we would look at in a nerve conduction study. And in a nerve conduction study, what we're doing is we are measuring the amplitude of a response at two different points, and then we can figure out what the speed of transmission is, depending how much time passes between those two locations. And so here they're showing us that it looks like there's a little bit of a reduction of the amplitude and that there's a little bit of spreading of that, and the velocity that they've calculated in the panel here is a little bit reduced at 24 meters per second. There is what we refer to as genotype-phenotype correlation in CMT. And really what this means is that depending on the gene that is affected in a particular case of CMT, that will affect what some of the clinical features will be. And so we have some patterns that tend to recur with certain genes that are summarized in this nice image from this review article. So we're always looking for some of these other issues and other system involvements in patients with CMT, because it helps us understand a little bit what the diagnosis may be or how to interpret the genetic testing. And on the flip side of this, if we find a gene mutation, let's say in one of these genes, and we know that that gene is associated with vocal cord paresis, or some respiratory involvement, that may tell us about things that we have to look out for as time goes on and as the disease progresses. So there are about 100 genes associated with CMT. So in a way, it's 100 distinct genetic disorders that fall under this umbrella. But I'm not going to list or go through all 100 of these. That would take a long time. I will tell you that there are 4 genes that are particularly common and important. About 90% of cases are really associated with these 4 genes that are very common. So in many centers, there will be a panel that includes these 4 genes that people start with up front. And then if it's negative, you proceed to a broader panel that includes these 100 or so genes. But again, if you were unsuccessful at getting a diagnosis with these first 4, then everybody else who you're testing for the other 100 genes, it only makes up the remaining 10% of cases. There are also certain founder effects that can occur. A founder effect is when a particular genetic mutation becomes more common in a specific population, usually because that population was isolated for a while. And so we know that there are certain genes that aren't among those first 4 that will be common in certain regions. So that's why I always ask for people's ethnicity when I'm doing these assessments, because it helps me know what to expect when we do genetic testing. The other thing is that the diagnostic yield, meaning the likelihood of getting a clear genetic diagnosis, is different depending on the clinical presentation. So in the demyelinating type of CMT, we get a diagnosis in around 80% of cases. And most of this is driven by the common mutation causing CMT1A, type 1A, the most common cause. Now, as soon as we get to the other subtypes of CMT with axonal involvement or intermediate, meaning mixtures of demyelinating and axonal, or pure motor, the likelihood of getting a genetic diagnosis goes down. Now, you may ask me, what happens to those people who do not get a genetic diagnosis? And the answer is that clinically, they still have a diagnosis of CMT or motor neuropathy or whatever, is the closest description that we can give, but they just do not have a specific genetic diagnosis at that time. As genetic technologies evolve, hopefully, these numbers are going to improve and we get closer to 100. Or if some of these cases are not genetic for some reason, hopefully we start to understand what the underlying reasons are for that. In terms of the clinic, so in terms of the process that most neurologists will go through in their clinic in order to get a diagnosis of CMT, this is really the pathway that I go through in diagnosing patients. And it is relatively, I would say this is a relatively newer approach in the last 15 or so years since we've had more access to genetic testing. 20 or 30 years ago, we really would have only had access to genetic tests and we would have relied more on other tests. But generally, I'll try to understand the clinical phenotype by doing the exam, hearing about the symptoms, maybe also including the nerve conduction testing. We start out with targeted testing. And again, as I mentioned, these 4 genes make up already the vast majority of diagnosable cases. If that is negative, we will go to broader testing, which either includes these sequencing panels or exome sequencing, which sequences all of the genes. And if we identify genetic variants that look like they could be the cause of disease, then we go through something called reverse correlation. And reverse correlation is kind of like, I guess it's kind of like Jeopardy, where you have the answer and now you're trying to figure out what the question is for the answer. So, you get a mutation in this particular gene. Okay, it's, TRPV4. So I know that that one is associated with vocal cord paralysis. Is that there in this patient, for example? So usually in that situation, I'll go back and repeat the history and the examination to try and tease out some of these features that I might have missed before. Occasionally, we will do nerve biopsy. I mean, I've listed it here, but it would be pretty unusual for us to really want to do this test because people are left with pain after the procedure, which can be long-standing. But there are particular features on nerve biopsy that can sometimes point us to a particular gene. And increasingly, we're starting to see use of MRI to help us in distinguishing cases. But I would say that MRI in CMT is at a very early stage right now. We have some examples in pictures here. This is what focally folded myelin looks like here. A couple of examples on the pathology slides. And here's an example of what the MRI look like in CMT. These are slices through so they're cross sections through the lower leg. And you can see that there is a slightly different damage pattern depending on the subtype. So in CMT1A, the peroneal muscles over here are more involved. In CMT2A, with early onset, you have relatively diffuse involvement of the muscles. But in the later onset CMT2A, you can see actually that there's relative sparing of the peroneal muscles. So almost the opposite of what you see in CMT1A. And in DNM2, they give this example of some of these deep muscles that seem to be spared. So this is, use of MRI is pretty early on and mostly being explored in research papers at this time, but it may be something that we start to depend on more. Getting a genetic diagnosis is very important, even if it doesn't result in a change in patient care. It helps us be sure about what the risk is to other family members. If we know what the mutation is, allows us to prognosticate and do screening. And I should emphasize that treatments that are in development are gene specific. So to be eligible for some of these treatments, we will need to have a genetic diagnosis. And I think I'm running low on time, so I better hurry up. For example, from CMTRF, they have some of these nice figures which show you the progress of some therapies for specific subtypes of CMT that you can check in on websites like this and see where future treatments are in the pipeline. But at the moment, we do not have a disease-modifying therapy for CMT, but I'm hopeful that that will change. So I will skip through some of these. So, to summarize, very detailed clinical assessment is still what we depend on in diagnosis of CMT. Most of the diagnosis does come from 4 particular genes with exceptions. We're much better at diagnosing people thanks to broad-ranging sequencing, and it's important for us to get a genetic diagnosis for future therapy. And with that, I will pass it on to Dr. Plamondon, and thank you.
So, hello everyone, I'm Stephanie Plamondon, and I will be presenting mostly on the management phase, the rehabilitation strategies in Charcot-Marie-Tooth disease. So I'm quite fortunate to work with Dr. Pfeffer in the South Health Campus Neuromuscular Clinic in Calgary with a fantastic multidisciplinary team, seeing a variety of neuromuscular conditions. And I'm going to start off by just talking about what is a physiatrist, because a lot of people may not have heard of that type of medical specialty. And I'll start off by telling you what we're not actually. We're not a physiotherapist or allied health professional who provides hands-on assessment and treatment for mobility problems. And I'm not a foot doctor or podiatrist, though I do address foot and ankle problems sometimes. And we're not mental health experts or psychiatrists. Those are the common three things that we seem to get mixed up with. But what we are is medical doctors who have completed training in the medical specialty of physical medicine and rehab. And PM&R is one of 29 medical and surgical specialties recognized in Canada at the Royal College of Physicians and Surgeons. We are nerve, muscle, brain, and bone experts who treat injury or illness non-surgically to decrease pain and restore maximum function. And our core values are really around the World Health Organization International Classification of Functioning, Disability, and Health. This describes the impact of disease at different levels on the whole person. So impairments really refers to problems with body structure or function, for example, weakness or swallowing problems. Activity limitations really are the difficulties someone might have in performing their daily activities, everyday things like walking or dressing or bathing. Restrictions in participation refers to various roles in the community, like employment or family life or leisure activities. And the contextual factors refers to those things that affect a person's experience of living with their condition, like the attitudinal or social environment, the physical environment, and personal characteristics like coping style or education, gender, race. So most types of hereditary motor and sensory neuropathy share similar symptoms of slowly progressive weakness and sensory loss in the feet and ankles, hands and wrists, and activity limitations that might limit quality of life and negatively affect it. A study of 407 participants from the Inherited Neuropathies Consortium of Rare Diseases Registry out of the US, the UK, Australia, and Italy was conducted to determine how common and what impact various symptoms may have on persons with CMT. And the survey really confirmed that mobility, balance, foot and ankle and hand and finger weakness were the most impactful and the most common, but several other themes did emerge also, including fatigue and pain, body image. These authors then went on to develop and validate the Charcot-Marie-Tooth Disease Health Index in 2018 with 18 different themes for patient-reported outcomes that could be used in research trials. So what does a physiatrist do if someone with a neuromuscular condition like CMT is referred to them? We really work with the multidisciplinary teams to assess several of these different things listed here on this slide, assessing the risk of falls, the walking or gait pattern and mobility, the independence level, hand weakness and dexterity. We assess for any painful conditions and then try to identify the most likely pain generators and apply the most appropriate physical, medical, or injection therapy treatments. We may be assessing and treating fatigue, maybe ruling out other contributors to fatigue, because that can be quite a vague symptom and may be contributed by several other things like sleep problems or physical activity levels, other medical conditions. We prescribe exercise programs, and we might prescribe braces or other equipment. And we are also often trying to be advocates for our patients for accessing support or funding. So as opposed to physiotherapists, our assessments often can overlap and can be complementary. So a physiotherapist may be focused more on the assessment, hands-on treatment of joint and muscle pain, applying gait aids and fitting people properly, like assessing them for a cane or a walker in the right height and having them applied properly, as well as providing more hands-on instruction and monitoring of exercise and other physical therapy techniques. Whereas the physiatrist may also contribute or combine with physiotherapy to add other possible treatments. So if we take the mobility goal of walking, for example, and look at the typical biomechanics of a walking pattern or the human gait cycle, our muscles are automatically timed and coordinated to fire in a particular repeating pattern to produce the most energy efficient gait. Our center of mass is in front of the lower spine and the mid pelvis, And energy efficient walking allows only very few centimeters of circular motion of that center of mass by timing the muscle contractions of different muscles in our legs, as well as the angles at which our joints are positioned. So in the case of hereditary nerve diseases like CMT, changes to foot alignment, foot and ankle muscle strength, range of motion, and sensation can create changes in walking pattern and balance that negatively affect the energy efficiency of moving. We require controlled dorsiflexion, or making initial contact with the heel of the foot and controlling how the rest of the foot lands on the ground, and plantar flexion of the ankle, controlling the forward movement of the lower leg over the foot as we fully transfer our weight onto it, as well as powered plantar flexion, to be able to push off by contracting the calf muscles to lift the foot off the ground again, preparing to swing the leg through as some of the key determinants of efficient walking. So some of the most common patterns of compensation in walking for persons with a neuropathy is a high steppage gait. So this accommodates foot drop with more hip and more knee flexion to allow swing without tripping over the foot. But some patients might compensate in other ways. So one of our jobs is to assess how people are compensating. And sometimes those compensations also change over time. When high steppage gait occurs, there's more fatigue of the hip flexors, and hip flexor velocity decreases, as well as walking endurance. And with further progression, the calf muscles weaken, new changes may occur, including slower speed, smaller step length, some clumsiness, and even difficulty with standing and controlling that posture because of that weakness in the calf. Poor sensory proprioception, or sensing how joints are positioned in space, also further worsen balance and create a higher fall risk. So overall, there's an increased energy cost of moving, there's decreased stability, daily activity, and steps taken compared to healthy controls in studies. So as a result of the progressive disease process and its effects on movement, as well as how early during development it begins, there may be several reasons why a person with CMT may develop secondary pain. And one of our roles as physiatrists is to define the most likely cause of pain and try to apply those most appropriate available treatments. So you can see in this list, I've kind of separated musculoskeletal problems that can commonly be seen, as well as neuropathic or directly related to nerve pain. So for example, with development problems, the hip may not fully develop, and there's a slightly more common incidence of hip dysplasia, which can predispose to hip pain and osteoarthritis later in life, as well as a slightly more common prevalence of scoliosis or a curvature of the spine as examples. So when we think about treating neuropathic pain, there are several different classes of medications that have been studied, not necessarily just in CMT, but in neuropathic pain to manage symptoms. And if you look at this graphic, you can see the green circles are in the studies, the number of patients who improve with treatment. The yellow circles are those that improve with placebo or no treatment. And the red circles are the people that didn't improve with that class of treatment. So you can see we've got a ways to go actually in trying to best manage neuropathic pain, and sometimes it can be quite challenging. And sometimes we need to use more than one medication to try to provide a meaningful reduction in pain. And that's determined to be, in the studies, about a 30% reduction in pain. So for musculoskeletal conditions and for general exercise and mobility, there's several rehab strategies that can be employed, and the first of which is therapeutic exercise. So in terms of the research that's involved in CMT, there is balance training and pacing strategies for treatment that have not really been studied very well in persons with CMT, but they're very feasible and very safe, and they have the potential to improve balance and gait and reduce the risk of falls and fall-related injuries. And they have been studied in other types of neuropathy patients. Community-based aerobic cycling exercise and home exercise programs that include both stretching as well as endurance and resistance training for the large muscle groups like in the thighs and the hips as well as the shoulders have been shown to be helpful. And these are the studies that are involved with small numbers each. All neuromuscular conditions only have small numbers in their studies, but these have been shown to be safe and helpful at improving function. And in general, therapeutic exercise is just good for your whole body. It reduces mortality and morbidity by reducing blood pressure, the risk of obesity, diabetes, heart disease, osteoporosis, reducing anxiety, depression, and pain, and promotes sleep. Beyond therapeutic exercise, footwear and orthotics are important considerations. And there's a number of different things that could be helpful in a particular patient. So foot orthotics to support arches, metatarsal pads to support the pain of metatarsalgia, which is the pain across the balls of the feet when there's increased pressure there, as well as alignment of the toes. Custom shoes might be required if there's a lot of foot deformity, which make it difficult to fit into shoes properly, such as a deep toe box in the front, and high top shoes for ankle instability. And then when it comes to bracing, there's been studies that look at what effect bracing can have. And depending on the pattern of weakness and the progression of the disease, there might be different types of braces that should be prescribed or considered, as well as patient preferences, to be quite honest as well. As a rehab professional, we might consider the range of motion in joints, the deformity, if there's any swelling, and the motivation and need to access gait training to learn how to use the braces properly to walk in a different way than people are used to. So Minotti in this study showed that this type of anterior brace improved energy cost of walking with a lower level of metabolic effort. And of course, several may have seen thermoplastic braces. There's a number of reasons why thermoplastic may be better. They provide more stability, but there's also several reasons why patients don't like them. Some people find them heavy and bulky and don't like the way they look, and you might need an extra shoe size to fit them into your shoes. But they have also generally been studied, orthotics have generally been studied and shown to improve walking kinematics. There may be other options that patients may be more willing to use, like really lightweight carbon fiber versions, or if they have trouble fitting into shoes, external AFOs may be considered, or if they like to go hiking and they're really hard on their braces, external AFOs may be an option. So OT is another important member, occupational therapy, important multidisciplinary team member that would assist with many different functions, especially wheeled mobility. So physio often will prescribe gait aids. And OT will help teach compensatory strategies for dressing and bathing and activities of daily living, pacing strategies, adaptive devices for using in the kitchen or the bathroom, other equipment to help with transferring from sitting to standing or practicing those transfers, as well as the mobility devices like scooters, stair lifts, wheelchairs. And they also help with upper extremity and hand function. And so there's been a small study looking at neoprene thumb opposition splints that help with positioning of the thumb when the thumb is weak for patients with CMT to improve their hand function. And there's a number of different strategies that they may prescribe, like hand exercises, stretching, light weights for tremor on the wrists, and some sensory things like rubber gloves to try to improve function there. They also look at home modifications and accessibility, and work, driving, public transportation, household management. So they can assist with some of those struggles for some patients that are having issues in those areas. In general, swallowing dysfunction is not as commonly associated, but there are some patients who will have difficulties in that area, and that's where a speech pathologist will be needed. So speech pathologists do bedside observations of swallowing muscle strength and coordination, and do specialized testing like a modified barium swallow. And they may use a camera to look inside the throat to see what the swallow looks like as well. So they can provide strategies and recommend diet changes if there is a swallowing problem that is occurring, and follow people over time. They also assess communication problems if people have hearing loss, and work with audiologists or ear, nose, and throat specialists. Dietitians can be helpful for managing the risk of osteoporosis and fractures due to falls. It's always important to ensure adequate vitamin D and calcium intake, as well as protein intake for muscle building and bone building. And maintaining a healthy weight is vital for mobility. Good nutrition is also something that will minimize fatigue. CMT may predispose to sleep disordered breathing and is also more common in individuals with some individuals with CMT. And often it won't present as a shortness of breath necessarily, but more of a problem actually with sleep disturbance and daytime sleepiness and fatigue. So sometimes a respirologist is indicated, a lung specialist, to do specialized lung testing to check lung volume capacity, and also screen for sleep apnea and sleep clinic assessments, so that this can be treated with things like BiPAP. So in summary, multidisciplinary teams' approach to long-term management of CMT symptoms may include many different allied health specialists or team members, as listed here. It'll include lifestyle modification, gait training, fall prevention, exercise, pain management, and it might require some adaptive equipment. But we also hope as a multidisciplinary team to allow people to access the resources and funding that they might need, that we can apply for, and provide education for patients as well. So with that, I have finished my part of the presentation as well.
Thank you so much. Can you hear me, everyone?
Yes.
Great, thank you. And I'm not Homira, I am Alia Karim, and I'm also a member of the research and advocacy team here at Muscular Dystrophy Canada. Thank you both, Dr. Pfeffer and Dr. Plamondon, for such a wonderful presentation. At this time, we have a few minutes, and hopefully we can take some questions from our viewers this evening. I see we have a few in the Q&A. This one goes to Dr. Pfeffer. How often do you recommend that a patient without a genetic diagnosis of CMT get retested?
Yeah, that's a great question, and something that's something that I'm never totally sure about in my practice. I would say to some extent this is a judgment call. It depends. So I'm sure that's exactly the answer you were hoping not to hear, but it's a judgment call, and it will vary case by case. It will depend a little bit on what kind of test you had in the first place. Some tests are more comprehensive than others. It may also depend on the type of CMT that you have. Maybe you have a clear demyelinating phenotype, and there have been a few important recent discoveries that explain an important proportion of cases, and it would vary, it would justify more testing at that point. Or maybe you belong to an ethnic group where we've just discovered there's a founder effect for a particular mutation that you haven't been tested for. So it can vary a little bit, but as a general rule, what I would say is that the pace of discovery makes it that after something in the range of 5 years, it's probably worth reassessing whether there would be value in doing more testing. So I'm not going to say automatically there should be more testing, but usually what I do is after 3 to 5 years, I reassess with my patients whether there's been enough of an advance that it would justify doing more comprehensive testing.
Great, thank you. I'm wondering if you can speak more about the PXT3003 clinical trial in CMT 1A patients.
Yes, that is also a great question that I regret I'm not perfectly equipped to answer today.
No problem.
So yeah, but I understand that studies are ongoing. There have been mixed findings with this therapy, and I think that more needs to be done for us to really know whether this is going to be a treatment option in CMT1A. Hopefully it will be shown to have a benefit.
Great. And so the next question we have is, I have inherited CMT. My feet have shrunk after giving birth, literally. I was a size 5, no problem with pregnancy. Has anyone experienced this? No one has experienced this in my large extended family. Any thoughts? Not sure what let's see. Her feet have shrunk, but
so I've not seen it before. Dr. Plamondon, I don't know if you've got any experience with that.
Yeah, I don't know that I've been. It's been brought up before that patients have noticed that their foot size has gotten smaller, but I think with increasing atrophy and the toes curling and if it's more of a pes cavus type, I would imagine that the foot can get shorter but also taller. So perhaps, unless you're also referring to, when you're pregnant, you could have a lot of swelling and then your foot size actually goes up during pregnancy and then goes back down. But I think you're referring to actually your baseline shrinking. So I think maybe the kind of like imprint of the foot as the atrophy happens, as the arch increases, I would think perhaps the length of the foot may shorten.
Right.
But that's the only thing that I can think of that would explain that.
Absolutely. And are either of you aware of any clinical trials happening right now in Canada?
I am not.
Yeah, I don't.
In Canada, no.
I don't think so. I don't think that they're recruiting in Canada, to my knowledge.
Okay, great. Well, I know it is 5:30 right now, so we have so many questions. So I will do my best to get back to people, and hopefully, definitely reach out to us at MDC at research@muscle.ca for some questions following this presentation. I just want to thank all of our viewers for joining us this evening for this incredible presentation. And again, Dr. Pfeffer and Dr. Plamondon, thank you so much for sharing your expertise today. It was really incredible to hear from both of you. We really appreciate your time this evening.
No problem. Hopefully it was helpful.
Awesome. And we're getting some responses. Awesome work. Thank you all. Thank you. Everyone's wishing you a thank you. And definitely feel free to reach us at research@muscle.ca. Excellent. Thanks, everyone. Have a wonderful evening.